Annually, there are more than 50 million surgeries performed in the United States, with 2/3 of those patients filling an opioid prescription. Most patients take fewer opioids than the amount prescribed after surgery, resulting in excess opioid pills that are accessible to others. Over-reliance on opioids in the postoperative setting can have unintended downstream consequences for patients, communities, and our nation's overall societal epidemic. Opioids can often be prescribed to fill an efficacy gap left by local anesthetics during the 72 hours after surgery when pain is most severe. Most local anesthetics inconsistently provide pain relief beyond 12 to 24 hours. This may be due to inflammation at the site, which peaks around 24 hours postoperatively and remains relatively high through the first 72 hours, and decreases the ability of local anesthetics to penetrate the nerve cells. In the postoperative phase, the body also undergoes changes in how pain is perceived. If left uncontrolled, this can have a snowball effect, resulting in what's known as hyperalgesia, or an increase in the perception of pain. More effective pain control, especially in the first 72 hours, minimizes risk of hyperalgesia and development of chronic pain. It's also associated with improved functional outcomes, quality of life, lower opioid consumption, and lower risk of addiction. My region has significantly felt the impact of the opioid crisis. In Michigan, there's a predicted almost 3,000 drug overdose deaths between September 2020 and 2021. Because of this, my institution has been focused on moving to minimal or no opioid strategies. Multimodal analgesia, or MMA, in our postoperative patients has been a significant step forward. This involves using multiple non-opioid medications with different mechanisms of action to provide a synergistic effect that better manages the pain. By maximizing our non-opioid medications on a scheduled basis, we begin to treat and prevent pain before it occurs. We only use opioid medications for breakthrough pain, or pain uncontrolled by our scheduled non-opioid regimen. Acute pain in the postoperative setting often requires opioid therapy for full control, especially in the first 72 hours. Having a product like ZYNRELEF is a game changer to our multimodal regimen, as it better manages pain during the most critical period after surgery. Adding ZYNRELEF to our standard MMA regimen allows my institution to significantly reduce opioid requirements, related adverse effects, pain scores, and possibly overall functional outcomes. Pain, like any disease state, requires individualized, patient-specific medical management. Patients who are already taking prescription opioids, many with chronic pain syndromes, are at the highest risk of poorly controlled postoperative pain. These chronic opioid users require higher doses of opioid analgesics to control the acute pain. Higher opioid doses come with diminishing benefits and increased side effects. I find that using non-opioid analgesics like ZYNRELEF is often the most effective measure for patients who are already exposed to or are receiving opioid therapy. Maximizing our non-opioid analgesics provides our patients with the best pain control and overall outcomes. Among opioid-naive patients, using non-opioid analgesics can also help to prevent addiction before it starts by eliminating or reducing initial exposure to opioids. Even a week of postoperative opioids can increase the risk of addiction. Just a 7-day course of opioids can increase the risk of addiction by more than 2 times versus a 1-day course. So anything we can do to help prevent that while managing pain is something I strongly recommend. As a pharmacist, I assure our protocols at my institution align with national guidelines and peer-reviewed literature recommendations. Along with the surgical team, we have developed a comprehensive multimodal analgesic regimen that focuses on opioid-sparing interventions. We routinely review the current literature for effective non-opioid analgesics, including local anesthetics, to have on formulary to better manage postoperative pain, and thereby reduce or eliminate the need for opioid prescriptions following surgery. That's why I'm pleased that we made ZYNRELEF accessible to surgeons at my facility. ZYNRELEF is the first and only extended-release, dual-acting local anesthetic and has been proven to reduce pain intensity for up to 72 hours after surgery, reducing or eliminating the need for opioids in many patients. The active ingredients in ZYNRELEF, both bupivacaine and meloxicam, are contained in extended-release biochronomer polymer. This offers simplified administration designed for consistently regulated delivery of both active ingredients for 72 hours after surgery. ZYNRELEF has been developed to provide both clinical and economic benefits for facilities, including reduction in severe pain and opioid consumption, ease of use, favorable pricing, and improved efficiency. The primary reason that most longer-acting local anesthetics are less effective beyond 12 to 24 hours may be inflammation at the wound site, which increases the acidity. Acidity decreases the ability of local anesthetics to penetrate nerve cells and block pain signals. Inflammation peaks around 24 hours postoperatively and remains relatively high through the first 72 hours, with severe pain often lasting up to 72 hours. Healthcare providers often rely on opioids to pick up where local anesthetics leave off. In Phase 3 clinical trials, patients treated with ZYNRELEF experienced superior pain relief through 72 hours after bunionectomy and herniorrhaphy compared to those treated with placebo or what is considered the standard of care, bupivacaine hydrochloride. ZYNRELEF has been shown in multiple studies, along with a non-opioid multimodal analgesic regimen, to reduce or even eliminate opioid consumption and reduce severe pain in patients. In the EPIC-1 follow-on study in patients undergoing bunionectomy, ZYNRELEF with a scheduled non-opioid multimodal analgesic regimen of over-the-counter acetaminophen and ibuprofen had 77% of the patients required no opioids during the recovery through 28 days, and 71% did not experience severe pain. In a real-world setting in Part 1 of the HOPE study, patients undergoing hernia repair surgery were treated with ZYNRELEF as the foundation, along with an over-the-counter non-opioid multimodal analgesic regimen including scheduled oral ibuprofen and oral acetaminophen. 95% of patients in this study were opioid-free at discharge and remained opioid-free through day 15 of recovery. 91% of patients received no opioid discharge prescription. Among these patients, none called back to request one. We actually rolled out ZYNRELEF earlier than we initially projected. Due to the pandemic, we faced significant staffing shortages and needed more procedures done on a same-day discharge model, so we turned to ZYNRELEF. Originally, we rolled it out for our total knee arthroplasty population. As TKA is often one of the most painful procedures, we felt ZYNRELEF could provide the most significant impact for our patients. However, the results surpassed even our highest expectations. After implementation of ZYNRELEF as part of our Enhanced Recovery After Surgery multimodal analgesia protocol, we've seen significant reductions in length of stay and callbacks, increases in the number of patients being completed as outpatient procedures, and most importantly, clinically significant reductions in opioid use. Clinically significant opioid reduction has been cited to be equivalent to 30 oral morphine equivalents per day. The adoption of ZYNRELEF in our protocol has reduced milligram morphine equivalents well in excess of what is considered clinically significant. Prior to ZYNRELEF, our same-day discharge rate of patients who went home within 24 hours was approximately 55%. After implementation of ZYNRELEF, that rose to over 80%. We decreased our average length of stay for patients by an entire day, and our opioid consumption went from an average of 100 milligram morphine equivalents per day down to 20 to 30 milligram morphine equivalents per day for these patients. Our providers have also decreased the opioid prescriptions they need to send patients home with, and since implementation, they've not had one patient call back for a refill. My team's goal now is to reduce those prescriptions even further, thanks to the great pain control ZYNRELEF is providing in those first 72 hours. We now use ZYNRELEF for total knee arthroplasty, total hip arthroplasty, and bunionectomy procedures. There's interest from our surgeons to expand the use of ZYNRELEF to a multitude of other procedures now indicated in the expanded label. We are excited to see ZYNRELEF receive a significant indication expansion in December of 2021 to apply its benefits to many more procedures. We're looking forward to additional expansions. Throughout the process, our surgeons have had a very positive response to ZYNRELEF. They've seen its benefits from impressions in the operating room to patients' responses and positive follow-up visits. Now we have nearly 100% adoption by our orthopedic team. Our surgeons also mentioned they love how quick ZYNRELEF's administration is compared to their standard cocktail that requires 60 to 120 injections for appropriate administration. They also appreciate having the product ready to go in the operating room without the need to mix anesthetics or pharmacy to perform sterile compounding. They've nicknamed ZYNRELEF Magic Honey based on the viscosity and color of the product, plus the incredible pain control they are seeing in their patients post-operatively. Multiple surgeons have also mentioned the difference they are seeing at follow-up appointments, which is not surprising, given how established literature directly associates lowered postoperative pain scores with increased functional outcomes. The lower pain increases the patient's willingness and ability to participate in physical therapy sooner, which impacts their long-term outcomes. We're constantly seeing better pain control and improved patient satisfaction with ZYNRELEF. We've certainly been able to reduce opioid use and prescriptions at discharge thanks to the reduced pain scores we're seeing in the patients after surgery. From a physical and mental health standpoint, this will have significant impacts on my institution and community. Additionally, I believe ZYNRELEF's effects will have significant financial impacts for the community with regards to the opioid epidemic. There are many cost-value benefits of using ZYNRELEF, such as reduced costs in comparison to the competitors and time savings in the operating room and pharmacies. One could argue that ZYNRELEF doesn't have a true competitor, as no other product has proven superior to bupivacaine, shown efficacy beyond 24 hours, or has an extended release label. ZYNRELEF has done all of those. It's hard to name just one. Increased patient satisfaction and outcomes, reduced opioid use and opioid-related adverse events, decreased length of stays are all important outcomes we see as a result of using ZYNRELEF. I also would expect to see a direct impact in our community from the reduction of opioid prescriptions needed after surgery, as it lowers the potential for abuse, misuse, and diversion. Plus, ZYNRELEF is so easy for the surgeons to apply, and it has the opportunity to save significant time in the OR. Paired with the convenient packaging, allowing stocking directly into our Omnicells or Pyxis machines right in the OR, and the extended 36-month shelf life, ZYNRELEF is the ideal postoperative pain management option. Pain is the number one concern for surgical patients. To date, scientific breakthroughs have been limited in advancing effective and safe pain control methods. After reviewing clinical literature on ZYNRELEF, the synergies demonstrated by meloxicam and bupivacaine when combined in the biochronomer polymer were clear. I've been following ZYNRELEF for a while, as I was shocked by the clinical trial results initially. Proving clinical significance for a subjective measure, like pain, is difficult to accomplish, but ZYNRELEF was able to do it. I reviewed the data with the orthopedic surgery and anesthesia groups at my institution. We all agreed the data demonstrated statistical superiority to standards of care and significant opioid and pain reduction. After our discussions, we decided to incorporate ZYNRELEF as the foundation of our multimodal analgesia protocol. ZYNRELEF is performing as well, if not better, than what the evidence revealed in clinical trials. Using it now as a foundation to our multimodal analgesia regimen, we're often seeing better results than the pivotal trials for ZYNRELEF, which were completed without the addition of multimodal analgesia in order to discern the true clinical impacts of ZYNRELEF on its own. A common question I get from my anesthesia group is the release rate of the bupivacaine and what additional anesthetics can be used along with ZYNRELEF safely. So ZYNRELEF contains 400 milligrams in its largest dose of bupivacaine. So for instance, in a TKA patient, the release rate is very reliable. About 50% of that is released in the first 24 hours. So I've instructed my anesthesiologist to look at the total daily dose or total daily exposure of anesthetic for that patient. So with the ZYNRELEF high dose, the 400/12, milligrams of the bupivacaine. In about the first 24 hours, the patient's only exposed to 200 milligrams of the bupivacaine. And that's over a 24-hour period. If you take into perspective the fact that most anesthetics are rapidly acting and have a very short half-life, if it was directly injected, it would all be released immediately. Right at the site, the patient would have an exposure from 6 to 12 hours, and you may give doses well north of 200 milligrams. Our previous cocktail, we used ropivacaine, and that was 400 milligrams of ropivacaine in our cocktail. We since switched to ZYNRELEF, and since switching to ZYNRELEF, we still do adductor canal blocks in addition. Typically, the adductor canal block is 150 milligrams of bupivacaine, and then the patients are also receiving some anesthetic as a spinal. We have not had any last effects or any adverse events reported that were associated with anesthesia. So we've had great success with the total exposure that these patients are receiving, well within standard limits and below maximum tolerable limits for patients in the first 24 hours. Pain, being subjective in nature, is a difficult outcome to study. To date, no product has been able to repeatedly demonstrate statistically significant differences in pain scores and opioid consumption through 72 hours versus standard of care products, until ZYNRELEF. ZYNRELEF is a paradigm-changing pain management product that can shape and change the foundation of multimodal analgesia and how we manage postoperative pain for millions of patients. In my opinion, it is nearly unethical to not incorporate ZYNRELEF as part of a multimodal analgesia protocol.
Indication: ZYNRELEF is indicated in adults for instillation to produce post-surgical analgesia for up to 72 hours after soft tissue and orthopedic procedures, including foot and ankle, and other procedures in which direct exposure to articular cartilage is avoided. Limitations of use: safety and efficacy have not been established in highly vascular surgeries such as intrathoracic, large 4 or more level spinal, and head and neck procedures. Important safety information. Warning: risk of serious cardiovascular and gastrointestinal events. Nonsteroidal anti-inflammatory drugs, NSAIDs, cause an increased risk of serious cardiovascular thrombotic events, including myocardial infarction and stroke, which can be fatal. This risk may occur early in treatment and may increase with duration of use. ZYNRELEF is contraindicated in the setting of coronary artery bypass graft, CABG surgery. NSAIDs cause an increased risk of serious gastrointestinal (GI) adverse events, including bleeding, ulceration, and perforation of the stomach or intestines, which can be fatal. These events can occur at any time during use and without warning symptoms. Elderly patients and patients with a prior history of peptic ulcer disease and/or GI bleeding are at greater risk for serious GI events. Contraindications: ZYNRELEF is contraindicated in patients with a known hypersensitivity, example, anaphylactic reactions and serious skin reactions to any amide local anesthetic, NSAIDs, or other components of ZYNRELEF, with history of asthma, urticaria, or other allergic type reactions after taking aspirin or other NSAIDs. Severe, sometimes fatal, anaphylactic reactions to NSAIDs have been reported in such patients. Undergoing obstetrical paracervical block anesthesia, or undergoing CABG. Warnings and precautions. Dose-related toxicity. Monitor cardiovascular and respiratory vital signs in patients' state of consciousness after application of ZYNRELEF. When using ZYNRELEF with other local anesthetics, overall local anesthetic exposure must be considered through 72 hours. Hepatotoxicity. If abnormal liver tests persist or worsen, perform a clinical evaluation of the patient. Hypertension. Patients taking some antihypertensive medication may have impaired response to these therapies when taking NSAIDs. Monitor blood pressure. Heart failure and edema. Avoid use of ZYNRELEF in patients with severe heart failure unless benefits are expected to outweigh risk of worsening heart failure. Renal toxicity. Monitor renal function in patients with renal or hepatic impairment, heart failure, dehydration, or hypovolemia. Avoid use of ZYNRELEF in patients with advanced renal disease unless benefits are expected to outweigh risk of worsening renal failure. Anaphylactic reactions. Seek emergency help if an anaphylactic reaction occurs. Risk of joint cartilage necrosis and degeneration with unapproved intra-articular use. Animal studies evaluating the effects of ZYNRELEF following intra-articular administration in the knee joint demonstrated cartilage necrosis and degeneration. Chondrolysis. Limit exposure to articular cartilage due to the potential risk of chondrolysis. Methemoglobinemia. Cases have been reported with local anesthetic use. Serious skin reactions. NSAIDs, including meloxicam, can cause serious skin adverse reactions. NSAIDs can also cause fixed drug eruption, FDE. FDE may present as a more severe variant known as generalized bullous fixed drug eruption, GBFDE, which can be life-threatening. If symptoms present, evaluate clinically. Drug reaction with eosinophilia and systemic symptoms, DRESS. If symptoms are present, evaluate clinically. Fetal toxicity. Due to the risk of oligohydramnios, fetal renal dysfunction, and premature closure of the ductus arteriosus with NSAIDs, limit use of ZYNRELEF between about 20 to 30 weeks gestation and avoid use after about 30 weeks. Hematologic toxicity. Monitor hemoglobin and hematocrit in patients with any signs or symptoms of anemia. Drug interactions. Drugs that interfere with hemostasis. Monitor patients for bleeding who are using ZYNRELEF with drugs that interfere with hemostasis. Example, warfarin, aspirin, SSRIs, SNRIs. ACE inhibitors, angiotensin receptor blockers, ARBs, or beta blockers. Use with ZYNRELEF may diminish the antihypertensive effect of these drugs. Monitor blood pressure. ACE inhibitors and ARBs. Use with ZYNRELEF in elderly, volume depleted, or those with renal impairment may result in deterioration of renal function. In such high-risk patients, monitor for signs of worsening renal function. Diuretics. NSAIDs can reduce natriuretic effect of furosemide and thiazide diuretics. Monitor patients to assure diuretic efficacy, including antihypertensive effects. Use in specific populations. Infertility. NSAIDs are associated with reversible infertility. Consider avoidance of ZYNRELEF in women who have difficulties conceiving. Severe hepatic impairment. Only use if benefits are expected to outweigh risks. Monitor for signs of worsening liver function. Severe renal impairment. Not recommended. Adverse reactions. Most common adverse reactions, incidence greater or equal to 5% in controlled clinical trials with ZYNRELEF, are soft tissue procedures, vomiting, and orthopedic procedures, constipation, and headache. Report side effects to Heron at 1-844-437-6611 or to FDA at 1-800-FDA-1088 or www.fda.gov/medwatch. Please see full prescribing information, including box warning and updated warnings and precautions for serious skin reactions caused by non-steroidal anti-inflammatory drugs, NSAIDs.